This clinical vignette is hepatitis as a representation of secondary syphilis. This is a reminder that syphilis, also known as the great imitator for a reason, can at times and rarely present as unexplained liver dysfunction and mimic other hepatobiliary conditions that makes the timely diagnosis and treatment critical. So in essence, we have a 49-year-old male, previously healthy, that presented with the chief complaint of abdominal pain and generalized rash. He was hospitalized actually 2 weeks prior at an outside hospital. Records were not available and patient had no health literacy, and he had diagnosed with pancreatitis of unknown etiology. Nevertheless, cholecystectomy was never performed. Symptoms started around 2 months prior, with also findings of chills and night sweats. Patient denied providers, sick contacts, recent international travel, or drinking alcohol. The abdominal pain was unrelated to meals, and he also denied to nausea, vomiting, diarrhea. The sexual history, nevertheless, was very pertinent, and it revealed unprotected sex and a prior history of a painless penile lesion. The patient remained hemodynamically stable throughout his hospitalization, and on physical exam, the pertinent findings were dermatologically a scattered maculopapular rash that was present throughout the body, including the soles and palms, as can be seen in Figure 1. The abdominal exam was also the pertinent positive finding with right-sided tenderness to palpation but negative Murphy sign. Diagnostically, on arrival even, the patient demonstrated a cholecystatic pattern of injury with AST at 368, ALT 378, and alkaline phosphatase very high at 960. Otherwise, the workup had been negative, total bilirubin 1.1, lipase mildly elevated at 97, but not diagnostic. Acute viral hepatitis was negative. Hemochromatosis was ruled out. Ferritin iron within normal limits. IgG4 for immune hepatitis was unremarkable. Ceruloplasmin, alpha-1 antitrypsin, ALK-M antibody were all negative and demonstrated the more intensive workup that was done with the patient. Abdominal ultrasound revealed that the patient had cholelithiasis but no cholecystitis. The hepatic findings were indeed representative, likely of hepatocellular disease. There was prior evidence of pancreatitis, but on MRCP, because of cholestatic liver injury that was shown on labs, there was no biliary obstruction or gallbladder inflammation. Because of the findings of the rash and the pertinent sexual history, RPR was sent out and it was very elevated at 1 to 256 titer. Punch biopsy of the rash was performed and it was consistent with syphilis, as can be seen in Figure 2 and Figure 3. It revealed mild spongiosis, vasobacterial changes, and dense perivascular and periadnexal lymphoplasmatic infiltrates. In Figure 3, we can also see the treponemal bodies. So, based on these findings, the patient was managed for secondary syphilis with 2.4 million units of benzathine penicillin G. And afterwards, even after 2 days, the LFTs had a markedly decline, as can be seen in Figure 4. After 1 month, there was almost complete resolution of symptoms. In other words, we can clarify and say that this case demonstrates that the patient was experiencing hepatitis and likely a prior episode of pancreatitis secondary to syphilis. Very few case reports and small studies have been documenting this syphilitic hepatitis or pancreatitis. Extensive laboratory and imaging workup failed to provide explanation for the patient's medical problems, and the diagnosis only became evident because of the manifestations of the rash, the subsequent testing for syphilis, including the biopsy results, and the pertinent sexual history. Without these clinical manifestations, for example, of the rash, appropriate therapy could have been delayed. The rapid resolution of his symptoms and the normalization of the patient's liver enzymes after administration of the antibiotic further proves the diagnosis of syphilitic hepatitis without the need for invasive interventions such as a liver biopsy that could have been needed to guide management. This case teaches us to incorporate syphilitic testing into the diagnostic workup for unexplained hepatic or pancreatic abnormalities, especially when accompanied by systemic symptoms and pertinent sexual history. So the teaching point is a low threshold for serological testing can prevent misdiagnosis and avoid unnecessary invasive procedures. Thank you.